For those of you who don't know me, I'm Dr. Gaynor Watson-Creed. I'm the Associate Dean for Serving and Engaging Society here at the Faculty of Medicine, and it's under the Serving and Engaging Society portfolio that we have this partnership with the McEachern Institute. And I want to thank my colleagues from the McEachern Institute for their involvement and organization of these fascinating panel discussions. Tonight's panel discussion is called No Easy Answers, the complicated and involved practice of ethics in healthcare during crises. And I think for many of us who are involved in the healthcare system and many of us who engage with the healthcare system, we see those big, beautiful buildings, for example, on University Avenue, and we imagine that what happens in there is orderly and precise at all times. And when we think about ethics and the involvement in that system, we imagine that that is also orderly and precise, and we imagine things like columns and rows where you can put together beautiful descriptions of ethical dilemmas that might come up and somehow do a checkbox exercise that gives us the right answer for what to do at the end of the discussion. Tonight's panel presentation is completely going to disrupt that notion. So sorry for those of you who are looking for an orderly discussion of ethics. I think what you're going to hear from our panelists tonight is actually a very real discussion about what is involved in ethical decision-making during any healthcare incident, but particularly a crisis. And I think what you'll hear about is the challenge of that decision-making when it comes up against values that we hold, when it comes up against decisions around whose values might trump the values of others and why, when it comes up around very questions of identity in the healthcare system. All of those things play into decision-making in the healthcare system. And they're not the things that we normally talk about when we talk about ethical decision-making. And so tonight's panelist has 4 panelists with us, 2 from Dalhousie University and 2 guests that I'll introduce shortly. So then without further ado, let's get started. I'd like to introduce our first speaker, who probably needs no introduction here at Dalhousie University, Dr. Marika Warren. Dr. Warren is an assistant professor in the Department of Bioethics here at Dalhousie University and the network ethicist for the Nova Scotia Health Ethics Network. She's trained in philosophy and has worked to build ethics capacity and confidence throughout Nova Scotia's healthcare system. Dr. Warren has supported the healthcare system in its COVID response and in addressing ethical concerns related to resource allocation, and her current research focuses on public engagement around health policy, developing a national approach to triage, the role of ethicists in supporting policymakers, and exploring assumptions about the right reasons for healthcare decisions. I told you that this panel was going to get real fairly quickly. So without further ado, Marika, over to you.
Fantastic. Thanks so much, Gaynor, for that introduction. So I'm going to start off tonight by telling some stories in the hopes that this is going to help ground our discussion tonight in, as Gaynor said, the very real experiences of health systems, of clinicians and individuals as they worked to find answers to impossible questions that we were all posed over the course of the pandemic. So in keeping with the theme of no easy answers, I'm not making any arguments tonight about what we should do or should have done in any of these situations, but I'm hoping to highlight the values that were relevant as we tried to find a balance in that decision-making process. And hopefully that will help demonstrate why there are no easy answers, that we don't make any one choice without having to deprioritize other things that matter to us. And so as you listen to these stories, I invite you to reflect on how we make decisions in situations like this where there are no easy answers, because a lot of the work that we did in terms of ethics during the pandemic, it wasn't about finding what the answer is, it was about providing a process that helps us work through to what an answer might be in this case. So sometimes, as Gaynor mentioned, the hope is that ethics has the right answer. And if you just arrange things correctly and put them in the boxes, that's what will come out at the end of the day. But in the case of the questions of the sort that we're going to be talking about tonight, that's not the case. But I do want to contend that a well-developed, ethically grounded process can lead us to a more right answer, which is language that I have borrowed from Bashir and found useful. Or sometimes in the sorts of scenarios that we were looking at here, it was a less worse option than others on the table. And coming to decisions in that process that everyone can live with at the end of the day, even if it might not be entirely comfortable for everyone. And so the last thing I want to do before I get to the stories is just highlight that the fact that values matter in terms of our decisions is certainly not news. That was true long before the pandemic. And it's also not anything new that we need to explicitly identify those values and balance them in decision making. But the pandemic swiftly and unexpectedly shifted the context in which we were making those decisions and wherein that balancing happened, and it shifted it in ways that were meaningful for us. So again, thinking about, what can we learn in those contexts when things shift suddenly about the values that really matter to us. And so again, it was certainly a challenge, living and working for all of us through a pandemic. And again, we're still in it. But I think that it's also increased our capacity, all of us, both personally and professionally, to reflect on our values, to identify what really matters to us, and think about how those values should direct our action. And so this capacity is really essential. And so in terms of thinking about this entire lecture series in terms of reconsidering healthcare, that sort of consideration of values really provides us as for a starting point as we start to think about change at systemic and structural levels. So on with the stories. So the first story I want to tell is about data. So over the past decade or so, perhaps longer, we've become increasingly enamored in the Western world with the potential for increasing computing power to deliver insights. If we give it enough data, then it will tell us, what we should do. And so just as there's hope that ethics will tell us what to do, we presented with colleagues in data and analytics, and they feel that that same hope is sometimes put onto them as well, and that they're also forced to emphasize the limits of what they're able to do. But we really have this belief in the potential of data to deliver insights that can help us to do things better, more effectively, more efficiently, etc. And then at the same time, the widespread availability of information through various channels, global communication and connectivity networks, has put us in a place where we expect to know what's happening, minute by minute, immediately. And so, those two things came together in the pandemic alongside a growing awareness of the need to protect the confidentiality of personal health information as enshrined in both legislation and organizational practices. So hopefully you can see how all of these are going to come together in a lot of challenging questions during the pandemic. So one of the central questions around data for public health departments throughout the country and elsewhere in the world was about whether the context of the pandemic altered the commitments and obligations that we have around protection and respect of the confidentiality of personal health information. So in the early days of the pandemic, when case rates were quite low, so there wasn't as much information as is available now, there were a lot of times where, again, public health departments, medical officers of health were faced with requests for information from the public, from the media, from researchers about case rates and locations of those cases. And then they had to figure out how to report that information, but also how to relay it to the public. So knowing that there was stigma, real stigma experienced by both individuals and communities when information was shared, questions arose about what are the harms of information sharing. We often think of it as an unmitigated benefit. More information is better. But in this case, what were the harms? And again, who is going to be negatively affected by that? There are also worries about the willingness of individuals to share information with public health that was truthful and accurate if the confidentiality of that information couldn't be assured. And again, that information was key to guide the epidemiological response to the epidemic. And then at the same time, transparency was important to secure public trust, which was also necessary for compliance and following the various public health measures that were being imposed. And then individuals, though, also said, I need to manage risk in my own life. And so I need this information in order to try and either mitigate or avoid the risk of getting infected myself. And researchers certainly emphasized the importance of that data in order to better understand and respond to a novel pathogen. So I hope that illustrates just some of the reasons why in these questions around data there were no easy answers. So the second story I want to tell is about surgical prioritization. So postponing scheduled surgeries has long been used as sort of a release valve in the healthcare system. So when things become overwhelmed, we just postpone scheduled surgeries, and that will be a sort of a short-term or a Band-Aid response. But when you keep doing that, the challenge is that wait lists get were already long. They kept on getting longer, and the strategy of canceling surgery was one that we returned to over multiple waves of the pandemic without time for recovery in between. And so, surgical services have absolutely been working hard to address that backlog, although how long at this point that may take is anyone's guess. I went looking for information, and no one even wants to hazard a guess at this point. Back in 2020, estimates is that, and so early in the pandemic, is that it would take 84 weeks to clear just Ontario's backlog. So again, think of how much more we're looking at this point. But not all patients on surgical wait lists are equal. And so surgeons have had to decide which cases get done and which cases continue to wait. And again, with waiting, it's not that there's no cost or harm associated with that there's considerable morbidity, loss of social activity, sometimes loss of employment income, all that's associated with longer waits. Sort of some folks have said, our lives have been on hold waiting for this particular surgery. So the tendency has been to perform day surgeries, so that can be done quickly and at least in one sense, shortens that list fairly quickly, and in urgent cases continue to be done on the grounds that they have sort of the most pressing need. But the folks who are likely to need a brief hospital stay, so there's an identifiable group of patients who just never get their cases done. And so this has raised questions about if and when sort of continuing suffering and morbidity, not mortality, but morbidity in that particular group becomes enough sort of cumulatively to outweigh perhaps an urgent need, or to perhaps say we're going to take longer to clear this surgical backlog. We're not going to do as many of the day cases in order to address this other group of patients. So again, hopefully that clarifies at least why there are no easy answers to those questions, and certainly they're going to be ones that I think we continue to grapple with for the foreseeable future. And so finally, I'm going to highlight some questions rising for individuals and families. And in the interest of full disclosure, this draws on recent events in my own house when we all tested positive for COVID after successfully avoiding it for 2.5 years. And to be honest, we started to think we might be special and resistant, but we were wrong. We were not special. We are just as susceptible as everyone else. And so I imagine many of you have similar stories, and I think one of the things that stuck with me in some of the discussions that we've had, talking with Shelley Deeks, our current Deputy Chief Medical Officer of Health, is that we all have skin in this game. So there is no one watching from the sidelines, and that makes it different from a lot of other times when we've had to address some of these questions, again, with no easy answers in healthcare, that there's people who are able to take a step back. We haven't had that luxury. So as most of you are likely aware, there are currently no public health restrictions in place in Nova Scotia. So the guidance is to stay home if you have symptoms, to avoid high-risk people in places such as congregate living facilities, and to wear a well-fitting mask in public for 7 days. But that's it. So as a family, we had to then grapple with questions of what we should do in order to honor the obligations that we had to avoid harming loved ones, or others in our communities, as well as strangers. Again, recognizing that we had a whole host of privileges that allowed us to do that, and to, for example, stay home from work and rearrange our schedules to keep the kids out of school. But we had to balance that against a range of personal interests and desires, which included visiting with a 72-year-old parent who'd flown in from Alberta, pressing work deadlines that we were facing, a desire to pick up my holds at the library, and at a certain point, a need for more toilet paper. So having to think through all these decisions and having to consistently foreground the interests of others and weigh them against our own interests, it was hard. And again, I'm a person trained in ethics, and perhaps you think this should be easy for you of all people, but I'm also human, and psychology is such that those holds at the library were really, really tempting. I did manage to resist, just in case anyone was concerned. And so when we were down to half a roll of toilet paper for 4 people in our house, our priorities shifted a bit about trying to avoid contact with other people. But again, we found for us that there were no easy answers there either, that it was work to land there. And certainly these are not the only stories I could have told. And again, I'm hoping that folks can see themselves or their loved ones in some of these stories, but also that you're thinking of the other stories, other cases where there have been those hard questions without easy answers that we've been wrestling with individually and collectively over the past 2.5 years. And so, where do we go from here? So the focus of this speaker series, Healthcare Reconsidered, challenges us to look at what we've learned about values and about healthcare during a crisis and use that, along with that facility that I said we've developed in considering how we balance our values and context, to think about how we want to move forward, to build a health system that works better for everyone involved. That's from policymakers to administrators, to healthcare providers, to staff, to communities, to patients, to loved ones. So again, thinking really expansively about how those decisions we make in healthcare affect everyone. Sometimes we tend to focus on patients and loved ones, but I think what we've seen during COVID, one of the things is the toll on those who are designing and implementing healthcare has been significant, and that we have also ethical obligations to attend to that. So these stories I've told, they highlight that there are no easy answers, because any decision in the healthcare system is going to affect many others. And so anytime our decisions affect others, that's when ethical questions arise about how we should act. And we need values to support us in deciding how we should act and who is going to be affected by the decisions we make. But perhaps more importantly, we also need to work out how we translate those values into daily practice in healthcare, and how we, again, might do things differently and embed those values as we take them seriously and the commitments that they generate, and use that as a foundation for catalyzing the systems change that, again, this panel and this discussion in the series is oriented towards. And so with that, back to Gaynor, back to Gaynor for an introduction to Max.
Thank you, Marika, for that. I love the way you took us through this question of, how do our values shift when they're challenged, and what challenges them? And also these, sort of deeper questions around, is there such thing as unmitigated benefit ever? And how do we look at what the risk might be, even of those things that we think about as unmitigated benefits? What is the impact of the repeated application of Band-Aids in a system as complex as healthcare? And what does that teach us about sort of where chronic morbidity might actually need to outweigh some of our other considerations in healthcare? And then this question about, what do we do when we get to that point where our should-dos are bumping up against our want-to-dos, which I think is at the core of the values conversation. So thank you for that. Dr. Maxwell Smith is a bioethicist and assistant professor in the Faculty of Health Sciences at University of Western Ontario. Dr. Smith co-directs Western's Health Ethics Law and Policy Lab and is the associate director of the Rotman Institute of Philosophy, and has appointments in the Department of Philosophy, the Skulick Interfaculty Program in Public Health, and the Department of Epidemiology and Biostatistics. Dr. Smith is a consulting bioethicist at Sunnybrook Health Sciences Centre and serves or has served in numerous ethics advisory roles, including with the Ontario Government, the Public Health Agency of Canada, and the World Health Organization. His research is primarily in the area of public health ethics, with a focus on infectious disease ethics and the ethical requirements of health equity and social justice for public health policy, practice, and research. This does sound like an ethicist after my own heart. So, Dr. Smith, the floor is yours.
Thank you very much for that introduction, Gaynor, and thank you to Kevin and the McEachern Institute for the kind invitation to speak with you all tonight. In reflecting on the title of the series, No Easy Answers, I actually thought about one of the mantras, I suppose, that I've heard over the past 2.5 years that has actually been presented as an easy answer to most of the challenges we've faced. And I think that it's actually utterly obscured the importance and role of ethics in how we think about these challenges. And that's the idea that we should just follow the science, right? That seems like an easy enough answer. Just follow the science. So should we close schools and businesses to suppress transmission of the virus? Just follow the science. Should we restrict visitors to long-term care homes and hospitals? Just look at what the science says and do whatever that says. Who should receive priority for vaccination? That should be fairly straightforward. Just follow the science. And finally, should we require vaccination or masks in certain settings or for certain activities? Just follow the science. So this is presented as actually a fairly straightforward answer. We just need more empirical evidence. Follow the science has been uttered both as a mantra for pandemic decision-making. We're committed to following the science. So I've heard my Premier Doug Ford say that many times. Prime Minister Justin Trudeau, President Biden have often said we're committed to following the science. It's also used to justify actions that have been taken or have not been taken, right? We were just following the science, right? Don't blame me for whatever happened or didn't happen. So decisions should, of course, be informed by the best available evidence that we have, but the mantra of just follow the science is damaging because it obscures the inescapable role that values play in science and in health decision making. So science doesn't tell us what to do. One of the examples that I commonly raise in teaching this is actually a study out of Toronto and the Board of Health there that found that if we reduced the speed limits in Toronto from 50 kilometers an hour to 40 kilometers an hour, then we would have a reduction in pedestrian and cyclist deaths from motor vehicle accidents. Of course, if we banned cars altogether, we would have no pedestrian deaths. So the science can very clearly say what might happen, but that doesn't tell us what we ought to do, right? We do value, of course, reducing pedestrian deaths or cyclist deaths from motor vehicle accidents, but we also value other things like getting to work on time and getting places in a reasonably fast amount of time. So policy decisions always involve these choices between competing values. And so the science will never tell us what to do. And this is especially the case when we're faced with significant uncertainty, which we were over the course of the pandemic. To expect the science to tell us what to do is really a pipe dream. And so the upshot is that our attention has been focused in entirely the wrong place when pandemic decisions have diverged. Often I see, looking at Nova Scotia's response to the pandemic, comparing it with Ontario's, comparing it with other provinces, one might think that because we've reached different decisions, someone must not have followed the science, right? One of us is wrong. They didn't follow it correctly. And that clearly isn't the case. Something else is going on here. So consider the rollout of COVID vaccines. I was the ethicist on Ontario's COVID vaccine distribution task force. And often the idea there was, let's just find out who's at most risk from COVID and they should receive priority. But of course, we can think about risk in a lot of different ways. Risk of dying, risk of exposure, risk perhaps to the economy if certain people aren't vaccinated and get back to work on time. And so we can debate about what objective we actually care about and how we want to use the harm-reducing powers of our vaccines. And that choice, that objective, science can't tell us which one is the right one. That will involve a value judgment. And I often hear things, I don't know if you hear this as well in Nova Scotia, but whenever Ontario does anything that people don't like, they say, oh, the science must be different in Ontario, right? Because we're moving in a way that perhaps another province hasn't. So science can't answer some of the most fundamentally important questions we face during this pandemic, and I think most of the controversies we face can be distilled to these sorts of questions rather than the scientific questions. Questions such as, what do we owe one another? What sacrifices can we reasonably ask individuals to make to promote the common good? When are governments justified in intervening in an area as deeply personal as an individual's health choices? And how should the goods of public health be balanced against other goods like social and economic goods, if we can tease those apart? How should we make decisions involving trade-offs between those goods? And perhaps the most important question, the normative ethical question that ought to be asked, concerns what justice or equity or fairness demands that governments might do. Given the disproportionate burden that has been experienced by the least advantaged members of our society, we should be asking not only questions like, when is government intervention justified to reduce transmission, but actually what does justice require of governments to do to protect and promote the health of the least advantaged? One of the examples that I often raise is about mask mandates. If we have evidence that mask mandates in a university like Dalhousie won't necessarily change population level transmission dynamics, we might still have independent equity or fairness-based reasons to have mask mandates to make sure that the spaces that we are congregating in are as safe as possible for those that might be at most risk. So as we think about improving health systems and reimagining healthcare, ethics must be central to help make these value judgments explicit and systematize our analysis of them, as Marika has mentioned. So let's not fall into the trap of just follow the science. Whatever the science says, let's do that. And so to finish, I'd like to just focus in on a particular value, which I think has been overlooked, given our over-reliance on just follow the science. So just before heading here, I looked up the wait times for emergency department visits at a few hospitals back in Ontario. Most don't really provide us this information, but some do. The estimated wait time at Montfort Hospital in Ottawa is currently sitting at 16 hours if you arrive at the emergency department. That's similar at Children's Hospital of Eastern Ontario at CHEO, 16 hours before you see a doctor. It's even higher. We're told we're meant to wait or expected to wait 20 hours at London Health Sciences Centre before you see a physician in the emergency department there. To Marika's point, I actually have some updated data about surgeries. The Ontario Medical Association noted that the COVID pandemic has created a backlog of almost 20 million health services in Ontario, including 1 million surgeries. So this is a massive crisis. And so how should we think about addressing it? I'd like to make the case for the role of ethics in articulating the importance of collective preventive action. And that's something that I think is hard to do, or at least more opaque when we're talking about science alone without thinking about values. So back in 1999, Norman Daniels, Bruce Kennedy, and Ichiro Kawachi argued that medical care is, figuratively speaking, the ambulance waiting at the bottom of the cliff. Their purpose in constructing this metaphor was to highlight not only the largely reactive role that healthcare and our health system plays when it comes to our health, but also the cumulative impacts of social conditions over the course of our life. When our health system has experienced the crisis that I've just sort of articulated with wait times and backlogs, one might be inclined on the one hand to think we simply need more ambulances waiting at the bottom of the cliff, right? If all of us are getting sick and we're piling up, let's get more ambulances there. And certainly we do need to think about how we might structure our health system to respond to that need. On the other hand, one might be inclined to think we should do more to prevent people from falling down the cliff in the first place, or at the very least mitigate the harms that they might experience should they fall. We could, for instance, install a barrier at the top of the cliff to prevent those falls. Ethics is sorely needed to make the case for sometimes requiring collective action involving individual sacrifices to improve the functioning of our health systems and the health of the public. But contrast this quote that I've just provided you about the healthcare being the ambulance waiting at the bottom of the cliff with a quote from our Minister of Health in Ontario, Sylvia Jones. When Minister Jones was questioned about why the government didn't introduce more aggressive measures in response to some of the modeling that was seen, Minister Jones responded saying, "We wanted to make sure that the modeling was actually showing up in our hospitals." So in other words, we don't want to take drastic measures without seeing the actual impacts on our hospitals. Of course, at that time, it would be too late to prevent the impact on our hospitals. But it suggests that it's actually really hard for governments to sell this sort of activity or these actions to the public when we can't point to these strains on the health system. If our ICUs are overwhelmed, it's very easy to say, guys, we need to wear masks, we need to get vaccinated, we need to do whatever is required to get there. But in advance of getting there, we need to sell that to the public as well, and that's a much tougher sell. And I think that's where ethics can play a role to really articulate the obligations we have, mostly born out of justice, I would argue, to make sure that we're collectively working together to avoid some of these preventable harms that our health system might face. Thanks very much for your attention.
Thank you so much, Max. I mean, you didn't take us there directly, but I heard on the edges of your comments a comment on the prevention paradox that we're frequently facing in the healthcare system, which is this idea that if we prevented a thing, then it doesn't happen. But of course, if we don't see it happen, then how would we know that it would have happened if we hadn't done the prevention? And so you can do that dance all day, and yet we still have this requirement, I think, for collective preventive action, because those of us who are in the prevention business understand what it is that's actually being prevented when we do that. I'm reminded of the quote by the current medical officer of health for the city of Toronto, where she said, when good public health is happening, actually nothing is happening. And isn't that the point of that collective preventive action? I also love your nod to the limits of science and the idea that as much as we may have grown up in systems that talk about evidence-based practice, in fact, evidence-informed is as far as we're ever going to be able to go, because ought to do is a value statement that lives and breathes in our decisions, whether or not we want to acknowledge that it's there. So thank you for that. I'm going to bring us back to Dalhousie University now, and our very own Dr. Christy Simpson, who again may not need any introduction in this room. Dr. Simpson is an associate professor and previous head of the Department of Bioethics here at the Faculty of Medicine at Dalhousie University. She's also the department's coordinator of the Ethics Collaborations Team, which provides ethics support for Nova Scotia Health, the IWK, and the Nova Scotia Health Ethics Network that we heard about earlier. Her primary responsibilities in this role include ethics education and capacity building, policy development and review, and support for clinical and organizational ethical ethics consultations. Christy completed her doctorate in philosophy, specializing in bioethics in 2001. Lovely to have you here tonight, Dr. Simpson, and the podium is yours.
Thanks so much, Gaynor, and thanks for the invitation to be part of this panel. I think you're going to start to hear some resonating themes between the stories that Marika shared and what Max was just talking about. Because what I want to do is actually take you in a bit of a deeper dive into one of the values that I think the pandemic brought to the forefront, but also said to us as ethicists, and I think as broader communities, especially within the healthcare system, to say, what do we mean by this value? And how does this become part of our decision-making processes? And for me, that value is solidarity. So early on in the pandemic, we heard lots about we're in this together. And there were lots of rallying pieces about how do we find community and be in community with each other when we're in lockdowns. So we noticed the need for community most when we are separated from community. And so there was a big call towards let's be in solidarity together, let's follow the rules, do what we need to do to get out of lockdown, yes, but also to take care of each other. And I found this a very powerful call towards what do we owe each other? What does it mean to care about each other in that strong community-based sense that there was a piece of solidarity for people around? But as we started to move through some of those early phases of the pandemic, we also became very clear that that unnuanced sense of being in this together doesn't work fully. Because there's that part of, well, we might all be in it together, but we're not all experiencing it in the same way. Who is being harmed during the pandemic? Who is most vulnerable as part of the pandemic? And where our healthcare system is positioned to both take care of people with the virus, without the virus, and recognizing, well, how do we still think about prevention? And all of those other things that we look to healthcare in certain ways to do becomes a really critical piece of, well, how does that connect to solidarity and our sense of community? And so for me, during the pandemic, it's been a really interesting process of reflecting more deeply on a value that I've always said, yes, it's part of our healthcare system. I think in many ways, a sense of solidarity is why we have a publicly funded healthcare system in Canada, right? It's steeped into it about we want to take care of each other, recognizing when you need it, we want healthcare to be there for you. But then also going, if we're not careful, right, and this is the sense of solidarity at sort of at one level, it's an appeal to the universal human condition, right? It's an appeal to, well, we're all the same because we're all people, aren't we? And I think we've learned throughout ethics and through several iterations of different decisions, and particularly during the pandemic, is if we're not careful, that universal human condition then becomes essentialized. And I invite you to think about who are you thinking about? Who are you picturing in your mind when I talk about who are we in solidarity with? What do we mean by taking care of each other in that sense? And in that way, it starts to become more clear, too, that if we essentialize and really focus on the universal human condition, we're treating everybody the same. We're thinking about everybody as the same as the starting place. And we know full well social determinants of health make a big difference. We know full well that that operates to the favor of those who are privileged. Because who gets pictured tends to be mostly those who are in power, who have privilege. And even within the healthcare system, as much as we take care of and want to serve and really support those who are ill, those who are suffering, there is that part about are we configured in the ways to really orient ourselves toward meeting their needs. And one of the folks that I was reading about it, a person named, whose last name is Gaston Fernandez, apologies, I'm probably not saying that right, but he really talked about three critical aspects of solidarity if you're going to take a more nuanced look. And he talks about it in terms of relationships, in terms of commitments and goals, and actions. And so from a relationships perspective, it really asks us to say, who are we in solidarity with, and what defines the relationship? From the commitments and goals perspective, it's about what are we aiming for as part of our solidarity? Why are we in solidarity together? And where do those commitments come from? And then actions are about what am I willing to do, or what am I willing to give up in order to ensure the well-being of others? And I think that part of the pandemic really brought forward about that appeal to community, but also going, am I willing to give up things? Make sure that that community, meaning all of us, is taken care of. Right? The reference to toilet paper has already come up. Thinking about how did we behave when we were in our grocery stores? Do I take the last roll, the last package? Do I take the last 5 packages? Right? And that's one piece of it, about thinking about what are my needs and how does that relate to other people's needs? And then translate that into the healthcare system and thinking we have all sorts of different healthcare needs. We've seen escalating mental health needs during the pandemic. We've seen the effects on long-term care. And so in that sense, then I keep coming back to those 3 questions, or those 3 aspects: relationships, commitments and goals, and actions. And this is where we can think about another example, which is the visitor restrictions policy that's been alluded to. So in some places about support person restriction policies or about essential care partner restrictions, right? And you can see in the evolution of the wording, we're trying to be really clear about who gets into the facility and who doesn't, and what that relationship is to the person or the patient that might be in that facility. And I think it's also been so complicated because we want to flex those policies over time too, to be less restrictive when it's okay and more restrictive when we need to. But I think we've also then seen with our visitor restriction policies, and I'll just call it that for short, is safety the only thing we're concerned about? Or is safety from the virus the only thing we're concerned about? Because especially from long-term care, we saw what it means to be in prolonged isolation, not having contact. We saw the effects on families and friends, on healthcare teams, around not having those support persons visible and present at really critical times, giving birth, dying. As you move between different types of facilities, when you think emerge and acute care, to long-term care, to rehab, to mental health and addictions, what role those support persons or visitors or family and friends are playing in those places became very visible. And I know healthcare providers did everything they could to fill in those gaps and address it, but it also took a toll on them too. And so we need to then think about it from a perspective of who are we in solidarity with? What is the goal that we're aiming towards? And what are we willing to give up to ensure the well-being of others? Long-term care seems to have faded from the attention that it was getting early on in the pandemic. I'm hoping it'll still be part of how we want to change guidelines about how we want to improve our long-term care facilities. But it was so present. And I feel like it's not so present now. Are we in solidarity with those in long-term care? What's our relationship with those in long-term care? We've also heard a lot about who's the people that are, or the effect of the visitor restriction policies on those that are implementing them. If you're the screener at the door of our healthcare facilities, it hasn't been a pleasant experience overall for those folks. They've been the receiving end of anger, frustration, threats, and kind of going, well, what's the support from my organization? What's the support from the public? I'm trying to implement a policy that we're meant to follow that's for the good of all of us, but we clearly don't see it that way. So as we think about who we're in relationship with, how do we address it when we don't all see those relationships in the same way? And when we prioritize our relationships in different ways. And I think if you're a family member or a friend, it may be different than how you see it when you're a healthcare provider or a healthcare leader. When you're trying to decide, does this qualify as an exception to the policy or not? And knowing that caused tremendous stress on people too about trying to gauge what are the harms that might come by following the policy and not allowing an exception, and what are the harms if we do allow an exception in very rich and broad kinds of ways. And so I think as we come back to then that sense of solidarity and the appeal to solidarity, I think it does get us to think about, why do we have a publicly funded healthcare system? What do we want from that publicly funded healthcare system going forward in terms of relationships, in terms of what we're aiming for, And in terms of what we're willing to do for that, and what we're willing to give up in order to support healthcare. And that may be a different way of coming at it, but it's also recognizing we can't just talk about solidarity alone. It is about how do we think about solidarity in these ways that help us illustrate and draw out the best of some of the other values that have already been named too, about justice, about fairness, about equity. Because those values also give us rich insight into what are we thinking about when we're thinking about those relationships and what we're aiming for. But I think also the call to solidarity and to be thinking about solidarity also gets me to think about where are we headed from here, as Marika said too. About solidarity is a call to community in some senses. So what kind of community do we want going forward? Within healthcare, and as we think about healthcare and the healthcare system as parts of our community, and a part of the fabric of our communities, where do we want it to go? So who are we in solidarity with? What is the goal we're aiming for? And what do we each need to do and or give up in order to ensure the well-being of others?
Wow, Christy, thank you so much for those very thoughtful insights. You know, as you were talking, I was really struck by this call that I hear you making, which is to remember the variety of human experiences that are at the heart of any of our interactions in the healthcare system, and how it's so easy for us to hope that those human experiences are not there or don't have variation because they mess up the whole thing in terms of applying the policy. They're just too messy, and it would be easier if they weren't there. And of course, that's not real life. And I also loved, you know, sort of what I think I heard you sort of hinting at, which is this idea that we can't, on the one hand, say we're all in it together, but oh, by the way, I'm going to take the first off ramp I get because I can, because I have the power and privilege to do that, right? And so that's maybe is the opposite of that call to solidarity that you're referencing. So thank you so much for that. Dr. Bashir Jiwani is the lead ethicist and executive director for ethics and diversity services at Fraser Health Authority in BC. And so he's been here acclimatizing because of the jet lag for a few days. And so very glad that you got to do that. He heads a team that provides decision and capacity building support in patient care and at the system level when dealing with complex, ethically challenging situations in context of diversity. Bashir currently serves as president of the Canadian Bioethics Society, as a member of the Pan-Canadian Advisory Panel on a Framework for a Prescription Drug List, and on the core team for the Aga Khan University Thinking Group on Ethics, Stem Cell Science, and Regenerative Medicine. He received his PhD in Public Health Sciences from the University of Alberta. Dr. Jiwani, over to you.
I feel like I've been invited to a potluck dinner, and the people before me had great dishes, so it doesn't really matter what I bring. But I like the hosts, so I really want to impress them, so they invite me back, so I have to bring something. But then I also reflect on the fact that I'm using similar ingredients and cooking in a very similar kitchen to my colleagues, even though I live on the other side of the country from them. So I'm like, okay, this is going to be very interesting, very complementary in many ways. So the resonances that you heard Christy point to, you're going to hear in my talk as well. I do want to start by saying thank you and really appreciating Nova Scotia, Dalhousie University, the McEachern Institute, and the Faculty of Medicine for inviting me, for sure, for hosting the session. But I really think for taking the time to do the critical self-reflection that you're doing to learn these lessons and try to move forward. I think that that's wonderful, and I think we need to do much more of that. So I really do appreciate that. I thought I would sort of, well, let me just say it. So one of the things I know was interesting for me in the pandemic in BC was that all of a sudden, pride of place on TV was had by the provincial medical health officer. And all of a sudden, every day at 3 o'clock, the whole province waited with bated breath to hear, what is she going to tell us today? What is the update? What are the new changes that are going to be made? And it could be about masks, but it could be about schools. It could be about all kinds of things. And what I thought was interesting about that is that people started to see the relevance of all of these different dimensions of their life on health. I understand now that what happens in my business setting is going to impact my health and the health of my family and my community. The same with my school, public transit, transportation, whatever it is. So all of a sudden the dialogue, the conversation really changed in what I thought was an interesting and possibly wonderful way. potentially, in terrible contexts, of course. And what I notice as I participate in lots of conversations with colleagues about COVID, whether it's in the clinical setting, emergency room, people are trying to figure out how do we, we're feeling so much moral distress because of the enormously difficult conditions that we're working in, right through to policy forums, to, other people who are stepping back like we are and thinking about it. All of us are trying to make sense of COVID. And it's such a large, complex story happening at so many levels. It's happening internationally. It's just really, really complex in that full sense of that word. And each of us in our own lives are trying to make sense of it. And I wanted to reflect a little bit on the narrative of COVID. So where I'm going to go with this is to say that I think ethics has a really important role in identifying the very specific questions that we need to think through to make sure we're prepared for the future and dealing with these kinds of things, and providing the methods, the critical thinking from a values perspective methods that we can use to actually answer these questions. That's certainly something that ethics can provide. But I also think that ethics can help our broader society shape the narrative, the sense they make of the COVID experience. And I think that everyone is doing it in their own way, and I think we can try to maybe bring some harmony to this. I don't know, I'm hypothesizing. If we were to bring harmony to this, what would that look like? And I would suggest, and again, very resonant with what my colleagues have said. I was going to say wise colleagues, but it's resonant, so maybe that means that I'm wise too. I'm not trying to say that, so that's why I didn't say wise, but that my colleagues have already shared. So the first thing that I think I would say about the narrative that we should create or help to really help society get its head around in terms of how to make sense of the meaning of the COVID experience is that it's not about individuals. It's about communities, necessarily. Because the weird thing about COVID is that at the end of the day, I can't actually protect myself from getting sick. I need you to do things that are going to minimize my risk of getting sick. I don't have full control over that. So an individual rights focusing on what I can do and can't do and should be allowed to do, is actually not going to protect me from getting sick. We're in it together, as one of my colleagues already said. So that's one thing that I would say. And notice there that I am privileging the value of solidarity. So I'm saying that we need to think about this in the context of community and ask the questions that I think Christy very wisely asked us to answer or think about. The second thing that I think I want to suggest our narrative needs to point to, describe, is that it's not about anonymous populations. It's about specific subgroups of people. Like there are people in our community who we are trying to work with and shift their behavior, our behavior. And these are particular people. They're not just broad groups. So let me give you an example of what I mean. We would come out provincially, and please don't misunderstand me to say I don't think we should have provincial directives to deal with things. We'd come out provincially with directives about masks, about testing, about immunization. And yet in our health region, we would notice that there were outbreaks happening. And these outbreaks were happening where particular people lived. To deal with those outbreaks, we need to go to those communities, and we had to figure out what's going on? Like, what's important to you? Why are you not following the kinds of rules that we all want the province to follow in order to live? And we find out, well, you know what? In the region I live in, 1/4 of the people do not speak English at home. Our messaging is predominantly in English. So we need to figure out, how are we going to communicate? And it's not just the language, it's also the medium. How are we going to actually get these messages to these folks? We have the highest rate of new immigrants and refugees. And it's interesting because some of these populations come from places where they can't trust the health system. We grow up here, we have an inbuilt understanding that we're proud of the health system. We can totally go there for help. Well, that's not the disposition that some newcomers have. And so we need to figure out how to earn their trust and recognize they can actually take advantage of these resources. So you just have to know who these people are. And the kinds of things we ask for are just not possible for people. You've got folks who are have a substance use issue, and they are receiving a safe supply as part of a harm reduction program. They get COVID, so they're asked to isolate. How are they going to get their safe supply? You need to know who these people are in order to actually make sure that the rules you want to follow, they have the means to follow. So it's about practical subgroups and populate communities of people. It's not anonymous people that we need to change. So we need to know who our community is. And here, the values I'm prioritizing are things like equity and pluralism, which I'd love to say more about, but I won't at this stage. And then the third thing I would say that the narrative needs to shift to, as again my colleagues have already pointed to, is that this cannot be just about preventing death and minimizing illness from COVID. That's absolutely important when we're in the presence of a pandemic. But it's much more than that. On the one hand, it's about other values that are at stake in the situation. So, for example, are we just wanting to prevent immediate death from people who get COVID, or from preventing people from getting sick from COVID right now? Or are we actually worried about the number of years of life that of quality that people might have later on, and people like those who are prevented from getting what might look like surgeries that are
scheduled surgeries.
Thank you. Right? So there are interventions that we're delaying to save a life that's having a cost of quality of life of a number of years for people downstream. I'm just simply saying we need to take that, that's in the calculation that we need to take. We know, I'm not an economist, but we know that if it's the case that there's a decrease in economic activity right now, it's not just that the people who lose business right now are going to suffer, but it means that impoverished populations are going to be, there's going to be higher levels of poverty 10 years down because of this blip in economic activity. Again, I'm just simply saying that we need to have a broader view of what's at stake. In one way, because there are different values at stake. In the other way, because we have this habit of really being preoccupied with the pain that's in our face right now, and the pain that most middle-class people actually are most concerned about. But there are other things that we need to be worried about. We have a huge opioid crisis. The kind of mobilization of resources we saw for pandemic, why don't we see that in the opioid world? We have climate change is just an obvious huge example that we're not paying the same kind of attention to. We've talked about long-term care already. Simply saying that the narrative that we create for how to think about these things has to have a broader context than simply what are we going to do to save lives from people who might get sick from COVID. So that's really what I want to suggest. I want to propose that in addition to doing the critical thinking on specific issues related to COVID, we actually try to shape the way people make meaning of this, reminding them that this is about the community. Our community is made up of particular subgroups of people, and there's a lot more at stake in our overall well-being. And that's our goal, is to improve the quality of life of all of us as Canadians. And that's, I think, maybe what ethics might be able to offer. Thank you very much.
Thank you so much, Bashir. I mean, I really resonated with your idea around how if we're going to take seriously the idea of pluralism against the value of individualism, you know, we really have to wrestle with whether or not it makes any sense at all for us to try and take control over those things which we can't possibly have control, and whether or not it makes sense to impose our values on others, knowing that that creates the risk of a false narrative that actually we can't rely on. And so this idea of ethicists as sense makers, as narrative makers in terms of making sense of complex systems really resonates. So I have a feeling that we could stay here all night in this conversation, which has been absolutely scintillating, but sadly we do have to go. So I think we will bring the panel discussion to a close on a few notes. First of all, I forgot to mention that it's World Ethics Day. And so that's part of the reason for our panel discussion tonight, focusing on ethics. And I want to thank our panelists, Dr. Warren, Dr. Smith, Dr. Simpson, and Dr. Jiwani, for taking us through this fascinating sort of look at what are the ethical considerations that might inform our next approaches to healthcare crises in Nova Scotia and beyond. We do have a gift for each of you, so we will attend to getting you that in short order. It's been a pleasure. Have a good night, everybody.